I like her, so you can talk for one more second. Okay, good. Now, thank you. I used to be much more efficient at that. Okay, so this is about finishing up as much as I can about the antibiotic part of it, so we can start the rest of it, which is antivirals, antifungals, and antiprotozoans. So really, there's not a lot of. I mean, it's reviewing these just to give you what I think are the basics you'll need to know, particularly for this exam, because it's going to be a lot more detail for many of you going forward, of course. But it's like when I did that little pecking order, and I'll reiterate that again. You'll see when we get to the combination sulfa drugs, how they're the first, and we're going to see the rest of the order and the last is vancomycin. But we'll see the other steps in here as well. That's not something I'm going to add. That's my sort of approach. That was my approach historically for treating these things, and it was. But anybody who's issuing treatment has an idea of these different kinds of steps to deal with resistant organisms. It's very complex, and maybe that's the best frame for all this. So you remember last time we talked about the aminoglycosides. These are the type of things that are wonderful for gram-negative enterics, but the trouble is they're so harsh. Again, you have to monitor. You're doing blood tests for kidney problems, for renal toxicity. You'll learn about them. They're called BUN and creatinine. It's not my job to go into them, but that you're measuring. When you learn about kidney, you're going to learn about the fact that they have to get rid of a lot of extra nitrogen, and those are measures of how much extra nitrogen you have in your system, as well as hearing. And it's very difficult to assess hearing, particularly if you're dealing with elderly patients who might be on the way to hearing impaired anyway. But nevertheless, it's not effective against a lot of things, but it's darn good for gram negatives. The trouble is the side effects. That burst appendix, that's when you're going to use this. That person with a rupture in a bowel or genitourinary structure because of a tumor or something terrible, a blockage of some type, that's when you're going to use these kinds of things. They're very limited, other than for things that you can't treat. And you'll see streptomycin historically does play a role with tuberculosis. We're going to look briefly at anti-tubercular drugs. That's a very complex issue that we will revisit when we start talking about respiratory diseases, of which tuberculosis is very significant and, again, resurgent today. So, again, the one that I would remember here, hint, is really about Pseudomonas aeruginosa. It's not inhalational tobramycin. It is gentamicin. I wrote it before, Genta mycin. And it's really, it has to be by injection. And you have to, again, be monitoring those kidney parameter levels. Gentamicin, and very, very specific. And it's in this category called aminoglycosides. That is, so again, we do it by just like you did with the disinfectants and antiseptic by category. Antibiotics go the same way. Categories are important because I suspect that's the same thing you're going to see when you do pharmacology. Method here. Tetracyclines. It's almost like magic. We did penicillins, then streptomycin. The next one they found, which was also in a soil bacteria, which I think was related to or similar to that streptomyces, was tetracyclines. And these are, unlike, and this is the important part, and I should have mentioned before, unlike the aminoglycosides are one of the very few agents that are bactericidal in the category of protein synthesis inhibitors. After that, they're pretty much all, with a couple of little mini exceptions, bacteriostatic. So, and again, when this came out, all of a sudden we figured this is a cure for the common cold. This is the best thing since sliced bread, because it was the bacteriostatic happens to be a setback, but what they found out, okay, it was effective on certain gram negatives and gram positive. Originally, we thought it was effective on all of them. So when somebody had a staph infection or a strep infection or an E. coli, just give them tetracycline. In the old days, it was called terramycin. The problem is, and you can see the difference, it goes into prokaryotic but not animal cells. Okay? I mean, so, and again, the resistance is something where you get rid of it faster or you don't bring it in as fast. But that was sort of why it was looked at as being so wonderful. The problem is it's relatively mediocre when you're talking about a typical staph infection. Didn't work so well. If you're talking about an E. coli infection, not that terribly effective. But it had certain advantages. Okay. So, for instance, imagine something as potentially nasty as something like plague or something when we remember we talked about anthrax. Interestingly, in certain kinds of, let's say, unusual or much less frequent infections, this works really well. There was a scare with anthrax as a bioweapon back in the early 2000s, right after 9/11. So we thought this was more terrorism having to be domestic. That was one of the agents that was one of the drugs of choice. So it gives you an idea. Some of these ones that are sort of out of the blue do something effective. We use it in mini doses all the time for acne. We use it, I mean, it probably would work satisfactorily for Lyme disease, things like that. I mean, there's any number of, and you'll learn about which ones are which. There is a limitation. I do not know enough about the sort of a different category in the tetracycline category, the glycyl cyclines. Okay, wider effectiveness, only one currently approved. So I don't know enough to ask you questions about it, so I'll keep it relatively generic. The big problem, we can't use it in little kids. Okay, what it does is, the fancy word is called chelation. That means chelation means to latch onto something. It chelates calcium in children. And this is a biggie. What we'll see if we give it to it in kids, by the time their secondary teeth, they are a mess. They're permanently messed up. They're permanently discolored. And it's not something that is simple bleaching or anything like that. They are cosmetically a big problem. We're talking about major these days kind of cosmetic intervention, which if you're not familiar with, is very, very costly and not particularly pleasant experience. So that's we call that a contraindication. You don't use it. Everybody has to know it, because if you don't know it and inadvertently it was prescribed or you didn't catch it, that's big problems. So that's why I want to make sure you get a handle on what are the things that you really need to know, and that's one of them. That's that's a biggie. And if you didn't know that, if you went in that, then you're really missing a critical piece. I can't state it more so. Which technically means it affects hard tissues, because hard tissues get hard by absorbing calcium. Latches onto calcium. Got it? Good. The drugs of choice. So far, none of these I've been talking about for MRSA because they don't work. The drugs of choice for those who are allergic to penicillin fall into the categories of macrolide. Don't know why they call them that. Again, another one of these soil bacteria, similar to streptomycins, involves protein synthesis. Not often, it is, unless they are allergic for some reason, and that's possible as well. The biggest problem, and the parent of this very famously was called erythromycin. The problem with erythromycin, you had to do what called 1 QID times 10 days. PO. Sorry, that's pharmaceutical script. Nobody got pharmaceutical script yet? Oh, I love this. Yeah, so typically that one with a dot is sort of like tabs 1 unit. QID means 4 times a day. My Latin's a little rusty. Times 10 days, 40 pills. PO, pars oral, passes by mouth. See? You didn't know that. Prescriptions are Latin. Oh, you got to have a fancy piece of paper to write a prescription. Oh, any piece of paper. As long as you put RX, which means, believe it or not, recipe, because that's effectively what they were. RX, whatever your name and your numbers are, who's it going to, blah, 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 blah. And then the name, whatever it is, cephalexin. 500 milligrams, you put caps, things like that. And then you have to put the number. And that's a DISP, which means to dispense, which is Latin for dispense. Number 40, and believe me, you want to have a Roman numeral close next to it, because with pain medicine, you know how to click S moves, you know how to alter. Okay, sorry. And then the SIG, which is the order, is called signature. And that's like that 1Q ID, and then you're signing your name. So you'll have to learn, because you, at the very least, you certainly could be writing them and having someone sign off on them, and at the very least, you're going to have to be reading them. And if nothing has come to you by being with me for nearly a year, we have rotten handwriting. And you got to be very careful with that. For someone who should be more worldly, back then I was somewhat naive. We used to keep my prescriptions in a drawer where, like, the checkout window, where whoever was my office staff was there. And obviously I'd see, oh, I'd pull out in the drawer, write the prescription, put the prescription pad back in. A guy came in, and I always knew that he was sketchy about drug use. And another guy, an older guy, came with him. You know, maybe they're 15 years apart. Didn't know it was his partner. Not partner in that sense, but partner in crime. Partner. He distracted my assistant, talking to her, asking her a question. She kind of walked away. The one guy who was getting the prescription, the partner reached over. Next thing I know, I'm getting calls from cops, from pharmacy, from a guy who was from the state, from Harrisburg. The cop, he goes, "Did you write this prescription for 100 Percocet for this guy?" I was, you might imagine what I said. And I had to meet with him over here, up in, going up Route 8, in that area, like Pine, that area. We had to meet, grab lunch one day. He goes, he's showing me photocopies. He goes, "This is what they did." And I mean, they swiped my prescription pad. Some guy got caught. They had an alert out on him. He tried to pass one at one of the pharmacies, up there, like Grove City, that area. And the they had an alert, and they kind of delayed him. And the next thing you know, the cops were all there because they wanted to know if I would testify, which I didn't need to. But certainly, be careful with that stuff. There are people with not nice motives. I don't think I've recounted that story in years, but you've inspired me. Okay, the point I'm trying to make in a wording that all of this stuff, be very careful. Watch out for drug seekers. I always believe people. My instinct is I do not want to be judgmental. That is not my role. But every so often you get little things that in the back of my mind go, watch out. If you see somebody scruffy coming in, it doesn't mean they're drug seeker. People, I mean, I like to take them with that, but unfortunately, we learn by experience. I can't say that strongly enough to everybody. It's not easy because there's a lot of bad people out there. Nevertheless, back to this macrolides. Erythromycin was the poster child for this. Trouble is 4 times a day, and inevitably it clobbered your stomach. Okay, why do I have to take it and all that type of stuff? They even tried to mix it with that clavulanic acid. People couldn't even tolerate it. Okay, because that would have been like a la Augmentin, because the stomach was so bad. So what happened, and this was the magic of this, even though it was still the drug of choice and you had to use it, again, Pfizer Labs shared this with you before. They changed the way the formula was and created this magic. Azithromycin, which you call the Z-Pack. And in other words, it's 2 pills the first day, and for the next 4 days, 1 pill, all in the morning, and you're done. 10 days. So azithromycin, full name, not A, as an individual letter, is known as the Z-Pack. And magically, not only was it effective and easy to comply with, rather than taking 40, taking effectively 6 pills for a 10-day span, all early on, it didn't have the same GI effect. It's like it softened the GI blow. And it was it has been one of the really revelation in prescribing. And you can use this for walking pneumonia. You could use this for anybody who's allergic to penicillin you're trying to treat, routine kinds of staphylococcal, streptococcal, gram-positive infections. So it's a win. That is in the category of macrolides. As you can see, it's bacteriostatic, okay? Okay, and atypical pneumonia is walking pneumonia. This and tetracyclines are their drug of choice. We also use mini doses of both of these, meaning you're using what we call subclinical, a dose that isn't supposed to work, okay? But of course, we're using like for things like acne, we're trying to, and maybe some folks who have used this. It's not easy to treat that, okay? And so because effectively you're trying the bacteria that cause it when we get to skin are relatively fragile, so you do not have to use a lot of strong medicine to take care of them, but you do need to take it daily. So the Enterobacteriaceae are those gut gram negatives, useless. So E. coli, that kind of infection, forget it. Okay, and we'll look at resistant later. Historically, another category whose name was this is really to understand how you can create a 5-alarm fire. This is potentially a lethal treatment. No one's going to use it today. We were still using it 50 years ago when I started my residency, nearly 50 years ago. It's called chloramphenicol. There may be some applications where people are using it topically. It is, again, gram positives, gram negative, bacteriostatic, albeit, but this has become, if it's still used, a last resort drug. What they began to discover in the 60s, because it was around, it was destroying the bone marrow. Aplastic anemia. Aplastic means, plasticity means forming or shaping. So without shaping, anemia means basically it's clobbering first your white cells because there's less of them, and then your red cells, both of them, destroying the bone marrow. People were dying of massive infections. Your immune system was collapsing. It's the kind of thing that happens to people when they're subjected to radiation therapy. It destroys their bone marrow. Nowadays we have bone marrow transplant. Back then we did not, so they stopped using it. It's very, very famous for a lethal side effect on what was a very good medication. We were just, when I got started, it was starting to be phased out. We had one doc who was running the ICU who liked it. My orthopedic surgeons, who were basically my bosses, didn't like it because they were worried, they were using it intravenously. I'll have to do with legalities of it. Ooh. But particularly white blood cells go first because there's so many fewer of them. You did the blood unit in AP2? I mean, there's 1,000 times more red cells than white cells. Okay, so I mean, if you just the numbers tell the story. If you're destroying proportionally white and red cells are going to go away, and that's how you fight infection. Tell me you're starting immunology. Immune system yet? No. They've talked about innate and starting to talk about that. Happy days. I don't have to do it. The next line in the chain to try to treat MRSA. Here it comes after those sulfa drugs, which actually come after this. They're called lincoside. They have a really important niche. Their niche is this. Not a lot of things work against anaerobic infections. And the reason I have a ton of experience with them, they penetrate the glycocalyx, that sugar shell that we talked about. You see, go into sugar. Those that you were awake, that's a joke. The one that you would certainly is called clindamycin. Infection refers to as clindamycin. Very effective against gram positives, including a lot of MRSA, particularly when the right CA means community required. The big problem is, there C induces because it clobbers a lot of the gut bacteria attacks the gut, and incidence of C. diff and colitis, inflammatory problems in the large intestine. Pseudomembranous diarrhea back then, now it's just more basically related. It's very hard to treat anaerobes. We don't have a lot of records. We're going to learn about another one in a little bit called metronitis. Actually, it's a dual kind of agent. It actually is an antiprotozoan that happens to work very well in anaerobic bacteria. So it's really designed for anaerobic. Things that don't use oxygen are problems. Glycocalyx is something people who do a lot of orthopedic procedures constantly sticking in part pins, screws, blades, wires, nails, all stuff like that. It fix whole bones together. Around those things, and orthopedic implants like artificial joints, they form a glycocalyx around it, and that's where infection gets in. Infection gets trapped between, let's say, the pin and that sugar shell. To try to penetrate that, as opposed to having to take out the hardware, is very important. So we ended up, we have to want the hardware to go in there. So I had a lot of experience using that. Really have, it's almost like you have to figure out what to do. It's really important because of that MRSA. This is going to be my second go-to, but now you have to figure out the GI and all that stuff. But there was one called Lincocin, but really the one you'll see the most of, again, it's bacteriostatic. It works against gram-negatives and gram-positives. This is Bacteroides, you'll hear more about. The most common, I would dare say the most common anaerobe when we're dealing particularly with wound infections, particularly bite wounds, is Bacteroides. Okay. When you get somebody's in a fight and they hit somebody in the mouth, and we'll go over this when we look at wound infections. A lot of things that gets gassy and kind of blows up. We'll talk about bite wounds and stuff like that. You should be excited. Dog bites. We'll go in here exactly where to bite the dog. We're so mad at the cat for letting the dog. Go get him. The cat's faster. He doesn't get caught. Interesting. These next two categories are really these newer categories, and that's the next line. Combination sulfates, which are coming up next, glucosamides over there, and I'm not going to ask you about this, but for me, the next line are these. These are newer agents. Oxazolidinones, I hate to tell you, and streptogramins. They both are bacteriostatic, but, and as you can see, they were almost designed for MRSA. And what they did is they had another synergistic relationship whose names you don't have to know, and they named the medicine Synercid. So they combat protein synthesis. They have two of these agents that most likely became bactericidal. And that has been a big problem with them. They were very new at the time and very expensive. Exactly how they're compensated today, I don't know, since I haven't written for them in over 20 years. So the insurance aspect of them I'm unfamiliar with. So they're effective against a variety of gram-positive, including some resistant, that's MRSA, vancomycin, inhibiting translation, really useful, a new category. The newer it is, the more costly it is. And again, some of these are going to be, obviously I don't want to put a price on healthcare, but it is something I always try to keep in my back of my mind. So I thought that was worth talking about. Here are a few more, and we're getting mostly done with those. This is a super important category, and I'll give you the anecdote that I give to everybody, because we all heard it. This is an agent you're going to hear a lot about. The only thing that's controversial. What did I get?
I don't even want to talk about it. Just know I have my paper now. After 30 minutes, I have my paper.
Settled.
We're settled. We're great. We eat that.
Okay, okay.
We're ready.
Did you get something to eat before lecture?
Yes. I went 10 minutes earlier for the thing, everything. And of course, I was 30 minutes late at class.
Oh. Fluoroquinolones. Did you test for Cipro? I think I asked you. Nalodixic acid, those neat little discs. We did. Yeah, Cipro, and we should, because I had it. I made sure they had it years ago. Maybe if they're still there. I mean, because they're expensive to order all those little discs. Fluoroquinolones, the most famous is called ciprofloxacin. There's other ones. Levaquin. Those are some of the names you've become familiar with. The controversial thing about them, my wife and I, is whether it's Cipro or Cipro. Honestly, this came out back. I was in practice actively in the middle of my practice year. This came out. All the pharmaceutical salespeople came around and said, "This is the best thing since sliced bread. It works against staph. It works against strep. It's bactericidal, okay, and it works against gram negatives." And we all started to use it. Within 2 years, we were sitting around at conferences. This is what you wonder what doctors talk about when you go to conferences and seminars, and you sit around BSing other than about monetary things or family things. You sit there and somebody will say, "Have you been using Cipro?" "Yeah, I used it for a little while. I stopped." He says it works on gram negatives. It does not work on staph or strep. When you did those Kirby-Bauer tests, okay, that is a lab test. We're going to be giving for Kirby-Bauer any lab test, a blood test. Okay, that's called in vitro, in a test tube, in the lab. When we think about in vivo, it means in a living being. Things don't work the same. What you do in the lab tests are a snapshot. The results of that sensitivity, it's supposed to work. It's supposed to work, but it's in the lab. It's not in a person. There's a whole lot of stuff going on in a person. This is a classic example of what was unreliable. They did all the research, proved statistically in the laboratory that it attacked staph and strep. It did not work once you put it into the body. Something interrupted that mechanism. But it's wonderful against gram negatives, and it does work against some gram positives. Again, this is something you could easily use for anthrax. Maybe this is something you could use for other problems. There's nothing wrong with the agent. Okay? But the big, right now, is really a go-to for the typical gram negatives. It is bactericidal, and what it does is it kind of works on, remember, DNA kind of winds and unwinds and interrupts that. Okay, so I mean, it's a fancy enzyme called GNA gyrase, supercoiling, bactericidal. Okay, I mean, so it is really not a bad agent at all. That is, I have like about 3 years, maybe, and all doctors do. They have like maybe 7 or 8 antibiotics in their pocket that they use as go-tos, because you're very familiar with how they work, what they work on, side effects, how they work on particular patients, and we all do. We all have like a pocket full of medicines that we prescribe all because we're comfortable with them. You understand? Hospital's a little bit different because, particularly if you're in a teaching hospital, they're going to you're going to do trying a little bit, be a little bit more sophisticated at many times because of the teaching aspect of it, which is very interesting. So, finally, we're getting near the end. I'll skip this for just a second. Metronidazole. Remember I wrote you about anaerobes? This is the other guy. This is a wonderful, I'm here to endorse it. This is great for anaerobic infections. This is the drug of choice for C. diff. Interestingly, it's the drug of choice for anaerobic protozoan infections. When we get to Trichomonas vaginalis, when we get to amoebic dysentery and giardiasis, which are not bacteria, they are protozoans. It is a drug of choice because they have anaerobic metabolism. It interferes with it. It's been around forever. They'll tell you, to me, the biggest problem is a headache. It can be in a liquid, all three of my wonderful children, when I was away studying for board exams in '86, they all got sick from inadvertently contaminated well water. Because my secretary, my office manager at the time, she and her husband were watching the three kids. They loved them, and they all had diarrhea for weeks. It turned out it tested positive for I think it was giardiasis. It's like, understand, if you have well water in the septic tank, never the twain shall meet, or something foul, the well water. Long story short, they had to be on that. They flavored it for the little kids. They made it pineapple, or they made it grape. Easy to do. The pharmacies are happy to do that, and it worked. It worked very well. I had C. diff. That's what I took back in 2005. So it's hard to avoid these things, okay? Because you're kind of on the firing lines with you. And and C. diff is, again, because it's an endospore. That is when you're with a C. diff patient with hand sanitizers. You can use it afterwards. Why? That's hand washing, hand washing, hand washing. Mechanical action, soap and water has to be done. It's not even, it's mandatory. So so metronidazole, that's where it works. Very, very useful. Now, once we're getting to see these other ones, now we're going to start to get into some of the categories for anti-tubercular drugs. Okay, and they're tough to treat. This is one of them. This is maybe as go-to as anyone. So when they say mycobacteria, okay, this is a very nasty agent. Okay, it's called rifampicin, rifampicin, and it doesn't really, to me, and again, it works somewhere in the DNA RNA family. That's where you're going to see it. Mostly gram positives, but when it says mycobacterium, it's very sufficient. With a big problem with tuberculosis is we have to use, every time we treat it, you have to use at least 2 antibiotics and flip-flop them around, change them depending on the severity, because it inevitably gets resistant. It's a absolute bear to treat. People are on antibiotics for a year for the active disease. I mean, that's not unusual. Active Lyme disease, if you don't catch early, antibiotics for a year, not unusual. And oh, you're all going to see Lyme disease. My late dog Ralph, what a courageous battle with Lyme disease. We joke, he was funny. He tested positive for 3 weeks. You're a good dog, Ralph. So, moving on. And so we'll look at the anti-tuberculars when we get to tuberculosis. So for now, I'm just introducing it. Here are the combination sulfates I've been talking about. Animals lack the enzyme to make it. We have to get it in diet. Okay? So these are look-alike drugs. Somehow I remember the term competitive inhibitors. Do you remember that? Do you remember that? That's where they come from. Lookalikes. This is called paraaminobenzoic acid. This is sulfanilamide. So you can see the fact that that side chain effectively blocks the pathway here, and then this other one, trimethoprim, blocks another enzyme there. Is there resistance? Sure. But not nearly as much as you would think. What it did when they came out with these sulfa drugs, they called crystals to form in the kidney. They were using them a lot for urinary infections. Back in the 40s, when they were in their infancy, because they'd been around for a long time, they were used a lot. They didn't realize how it was formulated, led to those. How do I know this? My grandfather, back in that era, in the 40s or the 50s, lost a kidney, basically a kidney stop function because of crystallization. Now, he lived to be 86, and when the other kidney failed, that was probably 86, he was never going to be a candidate for anything like that. And he died in 1976. But so that was it was real. I remember my dad telling me about it, and I was very surprised when I learned about it for real when I began to study this stuff. But this is, and basically we use it for urinary tract infections. And like I said, when they were running out of stuff for MRSA, particularly what we call community acquired, they said, well, what have we got in our medicine chest? And they started testing for these combination sulfa drugs, and it goes under the trade name Bactrim or Septra. And they said, geez, it works. The thing, and pharmaceutical companies hated it. Here's this scourge that they could make, they're trying to develop. And this has been around for so long. There's a ton of generics. One pill twice a day for 10 days is easy to comply with. It works with, there's not a lot of side effects for it. For instance, my wife is allergic to it. Okay, they gave her that for, I think, for a UTI, and then it was like all of a sudden she get a rash, that type of thing. But that's really the limitation. And imagine that turned out to be, and it is. You can go there and pay for it without any insurance or anything like that. It's very, very expensive. If I get these days under $10, you get a 10-day supply easy. Okay, just to give you some ideas, some context. So all of that, and why is it no problem? We don't have this pathway. It doesn't interfere with anything we do. We have to acquire it through diet. Effectively, it's a B vitamin. You take a multivite with B complex, you got all the folic acid you need. Did you talk about folic acid in the nervous system? That should have been me. That's when they found out that babies were getting neural tube defects back in the day. And that's when they knew that prenatal vitamins were important. We start to understand the ramifications of inadequate. We should have, but we didn't. This back in the 50s, and it got a whole lot better today. For many of you who are going to go into maternal child and things like that, it's a very exciting field. So here they are, work very well. We don't use the membranes. Okay, you might see some cases where daptomycin is indicated. The trouble is a membrane is a membrane, and that is a real problem sometimes. This is, again, one of those things, because of such side effects, it's a drug of last resort. Polymyxin B is in that category, and the interesting thing is it's just topical. That's part of that triple. We'll get into this. We have what are called, it's all combination therapy, mycobacterium is tuberculosis. The vast majorities, okay, other than that, rifampicin has to do, I think, with RNA assembly. All the other ones for tuberculosis affect the capsule. Remember that whole idea, why we call it mycobacterium? It's got that thick, waxy capsule made of mycolic acid. And so if you can inhibit that capsule from being made, you can attack it. The trouble is, it's so hard to get through, you need a multi-pronged attack. Think battleground. So we have divided them over time into first and second line drugs. I'm going to go into all the names. Combination therapy, 2 or more at a time, increase the chance of this is all true. Very unique part of it is that cell wall. Years ago, isoniazid, there's a kind of tuberculosis where you have been exposed, but it is not active. Years ago, they used to use this if someone had been exposed, but really did not have the active disease as a one-drug thing. To give you a hint about toxicity, I was teaching this gal in 06, so 20 years ago. And the first exam, she got an A. Second exam, she got an F. And that was consistent with quizzes and lab stuff, because I taught both the lecture and lab at Chatham. She was doing Shayside School Nursing. Did you only study on every other test? Actually, I give my usual flip pattern. Oh, she goes, no, the isoniazid kicks in. She had taken care of an elderly aunt for years who had tuberculosis. The primary caregiver had tested positive. They put her on this for a year. And every so often the side effects are just like, I can't focus. Did you ever think of mentioning that to me? Well, I didn't think that was the right thing to do. That's what you're supposed to do. There's an appropriate reason to defer taking an exam. Have I ever refused any of you when somebody's been sick or had some kind of family issue or those type of things? No, that's because good teachers don't do that. I don't. So, moving on, just to give you an idea, there's a whole laundry list of these. I'm not going to go crazy about it on this test because we're going to get to tuberculosis later. I think the important things to know for the year is that we have to use combination therapy, and most of them have a lot of side effects. We'll get into the different types of tuberculosis. Oh, thank goodness. And I still have time. This is lab. Don't do it. Don't do it. I think you've seen this picture before. Don't do it. They have all sorts of wonderful tests, very attractive. My wife's got something like her screensaver, some type of weird looking thing like that. Okay, this is the one I've been telling you about before with resistance, and I'll finish with this. Only 3% of staff were 97% susceptible. Now, not only 90% are resistant, but now we're dealing with worsening resistance. So we begat, as I told you, first penicillin resistant and now methicillin resistant. This is a cell. So understand, without a nervous system, without a brain, without any resources, just from mutations and evolution from this constant onslaught of chemicals and the normal billions and billions of these living things, these living cells, they have formed enzymes to block to create resistance. They've altered. Remember I told you about the penicillin couldn't attach? They've altered that. They've altered it for some of the erythromycin. Okay, so you just have to know a laundry list. And they make enzymes. They alter target molecules. They actually, and this is almost only gram negatives. Remember that periplasm thing? They have what's called efflux pumps. So I mean, imagine in comes the medicine it's absorbed into that periplasm from the outer membrane. Before it gets to the inner membrane, there are pumping mechanisms to spit it back out. Pretty impressive for a single cell. Okay, and so all of that, there's a variety of things: elimination by efflux pumps, decreasing the uptake, and even inside they alter the target molecules, as you can see. There's a lot, and the last one is these are the efflux pumps that I was talking about. So you can see all of them. They can either decrease the intake by mechanisms, or they can increase the outflow. So there's a ton. Efflux pumps are there, changing the influxability. So they either decrease uptake, means less coming in, increased elimination means more being spit out, all from that periplasm. Wow, pretty cool. And we already know about resistance: spontaneous mutations, significant single base pair, resistance to strep. Just for instance, remember a population that's 1 billion cells, at least one has a mutation. The streptomycin is added, and only that cell will replicate, yielding a resistant population. That's why we sometimes, not always, have to use combination therapy. It's not necessarily, I do not know what we call it standard of care, what is typically done today. In our day and age, they used a lot of this. When they had bad infections, we'd use penicillin and streptomycin. We'd use more than one type in an effort to, because we had difficult patients in an indigent population, which if you didn't treat them successfully and efficiently there, you weren't going to see them again, and likely once they got back on the street, they weren't going to. We have a lot of homeless individuals, etc. It was a difficult thing. Sorry. And we already learned about this with gene transfer, resistance plasmids, spontaneous mutations, etc., etc. And I mean, now let's start here. I mentioned this before. On Monday, we'll start here. That's really the last part, the whole VRE and how we got to vancomycin resistance, because I think that's important. And as you back up, you'll see, good, gone past it. These charts give you an idea of some of the names, like azithromycin, that's there, doxycycline, which is known as minicin, you learn about. Here's the gentamicin, here's the clindamycin, here's the linezolid, this category, etc., etc. So just the names are there on the charts for your. your study. Thank you. Have a great weekend. Have fun.